All right, we're going to go ahead and get this session started. Welcome everyone to the 2023 PI Conference. We will get started in just a moment. My name is Emma Mertens, and I will be your moderator for today's session. We are about to start the session titled Leukocyte Adhesion Deficiency Type 1 or LAD1. I am so excited to welcome Dr. Uzel, who will be presenting this topic. There will be time for questions at the end of the presentation. Please submit any questions you have for our presenter in the Q&A box in the Q&A section of the platform. Dr. Uzel is a physician with the National Institute of Allergy and Infectious Diseases, focusing on both pediatric and adult patients. Welcome, Dr. Uzel. Thank you for joining us.
Thank you. It's my pleasure to be here with you and joining the IDF community and to talk about leukocyte adhesion deficiency type 1. Actually, this disease has a special meaning for me because it was the first immune deficiency disorder that I worked on as part of my fellowship when I joined the Laboratory of Clinical Immunology at NIH within NIH. So, and I'm going to go ahead and start sharing my screen. I think we should be okay. All right. So I titled my talk as "When Neutrophils Don't Run, Roll, and Squeeze." This is because this defect, leukocyte adhesion deficiency, is a defect of neutrophil mobilization. So neutrophils are major white cells of bacterial fungal defense. They travel in the vascular lumen, and they squeeze through the vascular endothelium to the tissues when there is the chemical signal, either really chemical signals, cytokines, chemokines, or signals related to bacteria and fungi. They travel from the vascular lumen to the site of infection or to the extravascular space. So what makes this move, actually, it happens in several steps. There is a rolling process where there's a very loose adhesion between the neutrophil and some ligands of the endothelium. There is tight binding, and then there is what's called diapedesis, meaning squeezing of the neutrophil in between the epithelial cells, and then migration of the neutrophil to the tissue. Our receptor of interest today, which is called CD18, or there are different names for this based on the couple it forms with the corresponding integrin. But let's call this our star CD18, is expressed on the cell surface. It's a transmembrane protein receptor, and it meets its ligand, which is on the epithelial cell surface, which is the most typical, most common one is ICAM1. And with this binding of its receptor, what makes promotes the binding and mobility of neutrophil to the tissues. So the important factors here, the things to remember, is that CD18 is expressed on the cell surface, but as a dimer. Dimer meaning it forms duplets with another receptor of its subset. It's called an alpha integrin. So CD18 is a beta 2 integrin. So based on the alpha integrin, it comes together to be expressed on the cell surface. It can be called LFA1, LFA2, LFA3, or CD11A, CD11B, CD11C, all coupled with CD18. So it's this dimer, though, to be able to form the dimer is one of the critical roles of CD18, because CD18 by itself doesn't get expressed on the cell surface. It has to be in a dimer with its corresponding unit. So just like basic biology. The rest of it is not going to be as boring. Let's see if I can move. All right. So what is leukocyte adhesion deficiency? I'm assuming there are some patients among the audience who are tuning in to listen about their own disease, maybe, or their family member's disease. But for those that don't know much about LAD1, I'll give an basic headlines. So it's a primary immune deficiency of neutrophil function. Neutrophils are not absent in circulation, but neutrophils are absent in the tissues. So if you ask some immunologists, they call LAD1 a neutropenia, lack of neutrophils in the tissues, because neutrophils stay in the circulation. They do not get to the site of infection, or have a hard time getting to the site of infection or inflammation in the tissues. So the neutrophils are defective in the biological terms for these functions are chemotaxis, which is the ability to be attracted, move to one side, margination, which is to be able to adhere to the vascular endothelium to be lined up, and then adherence, that really sticking. So these are the defective functions. They're how they are named. And then, but not only the problem is not just being able to adhere, move, but also they are not able to engulf, perform phagocytosis of the bacteria or bacteria particles that are coated with complement, because one of the dimers of CD18 that it forms with 11C is very critical for that complement-mediated bacterial killing. Thus, that in most sense, it explains the difficulty of handling bacterial infections. It is caused by due to diminished expression of this CD18-11 integrin dimers, but it is due to germline mutations in the gene encoding for CD18. So the gene name is ITGB2, and I said germline meaning patients who have these mutations are born with these mutations. These are not somatic mutations. These are not the mutations that occur later on in life in a subset of cells. So these are germline mutations, and it's due to it's a recessive disease, which means that both copies of the gene carries a mutation. It may be the same mutation in both copies, which would make that patient homozygous for that mutation, or it could be two different meaningful mutations, which would make that patient a compound heterozygote. And most of the time, either parent could carry one mutation, or one of the mutations can occur de novo in the very early phase of embryo or in the gametocytes. So it's not a rule that both parents have to be a caregiver, but that's the easiest most common way of inheriting, passing on the disease. So, as I mentioned, if someone has a difficulty of expressing CD18 or has very little amount of CD18, or expressing but this 18 may not be functional, some mutations lead to that, will lead to a defective bind between 18 and its ligand ICAM1 and ICAM2. Therefore, excuse me, would lead to a neutrophil dysfunction in terms of adhesion, chemotaxis, and phagocytosis. So this on the right-hand side is the representative linear figure of the CD18 protein. It's a transmembrane protein, meaning it is expressed on the cell surface. Excuse me. And it's a big part of it is expressed on the cell surface, and is glycosylated, meaning it has quite a bit site for sugars, and some changes in this gene coding, which we call variants or mutations, change the sites of this glycosylation, or change the way the protein folds, bends, which affects its dimer formation, and it is the site that it just locks onto ICAM1. So there are different biological, physiological implications of different mutations. Key features of this disease. So what happens when you have when somebody has leukocyte adhesion deficiency? There's leukocytosis, meaning white cell count is elevated in peripheral blood because they cannot move out of the blood to the tissues, and this leads to a relative lack of tissue neutrophils, leads to frequent systemic life-threatening infections, mostly with bacteria. And skin and soft tissue infections are also very prominent, can be very prominent. There is one of the bigger problems that we face with patients with LAD1 is the fact that they have very poor wound healing. Develop skin ulcers called pyodermal gangrenosum-like skin ulcers. Poor wound healing because we need neutrophils in the tissues to heal properly, and there are other elements, that other cells that are involved in tissue healing, wound healing, and CD18 is important in their function as well. There is most patients have severe periodontitis and gingivitis, meaning loss of bone, apical bone, and gingival inflammation, and they end up with loose teeth, and most patients end up losing their teeth. And we actually, to prevent this gingivitis inflammation and lymphadenitis related to that, we electively do dental extraction and fit the patients with dentures sometimes. The less common or less known features of this disease is inflammatory bowel disease, closer to Crohn's, but a little bit different in pathology. And there is a feature of autoimmunity. It's not just neutrophil defects. There is predisposition to autoimmune disorders in patients who have leukocyte adhesion deficiency. One big problem is that we see warts quite a bit, flat warts, warts, cluster warts on the hands, and sometimes extensive perianal and genital warts. That's a big problem. That's one issue that is hardest to deal with. And then patients can also get viral infections, viremia with Epstein virus, virus, the disease, the virus that causes infectious mononucleosis or kissing disease, and it's normally a dormant virus, but patients with LAD1 can get intermittently viremic, meaning that this virus replicates all of a sudden quickly in the peripheral blood, and then kind of calms down. We haven't seen any explosive EBV-related disease, but we keep watching on the virus and its effects on patients who have this infection. And actually, the majority of population gets exposed to EBV at some point in life, and most people, most kids get preferentially get exposed to it before college, and it's the college kids that you hear about, that the kissing disease, when they, if they're naive, they go to college and they get this, they get huge big lymph nodes and swollen tonsils and enlarged spleen. In healthy individuals, it usually is limited, but stays dormant. So let's talk about the diagnosis. Now we are living in the age of genome and exome sequencing. In the past, when we suspected the disease, clinically, we did targeted sequencing of the gene for CD18 or LAD1. That's meaning that we only sequence that gene. But now, when we suspect somebody having an immune genetic disorder, we don't even have to name it as LAD1. We request a panel screening or a whole exome. We at NIH, we moved to whole genome sequencing, that we get a reading the mutation, and finding the mutation and validation of the mutation is the basis of diagnosing this disease currently. There are some variants in this gene that may not be functionally relevant. That's why when there is a variant that comes out from sequencing that has never been described before related to LAD1 deficiency, there's a process called verification of the variant, or verification of the mutation, where we do functional assays and try to understand if those are really, those variants are really responsible for the disease or not. Often we don't have to, because some mutations are deleterious, meaning that they cut or chop the protein, or they have been described before, published. In those instances, you don't have to do very detailed mutation verification or functional validation. So there's this whole issue of functional validation still, if when we want to understand if LAD1, how functional CD18 is. Still, there are several patients we have followed over the years where they had a mutation that lead to diminished function of CD18, but not necessarily absent function. So you want to have an understanding of how functional this result in CD18 is. And that's when functional studies come in play. And there are several different ways of doing this. We have done this over the years, and especially in the days when people wanted to classify LAD1 severe or not severe. Right now, you know that we believe in the fact that the less than 2% expression, more than 2% expression is a very arbitrary limit that was initially set, and that classification of severe, non-severe is not holding up currently today, at least in our clinic, in our research. I'll give you an example of a clinical caveat of a patient. Then I met this patient when he was 31 years old. Who initially presented with poor wound healing after a tracheostomy. for a complicated coup at age 10. So he was not one of those who had delayed cord separation that we get taught about in medical school. He didn't have extensive bacterial life-threatening infections early on. But the first time he ran into trouble, that was after a surgery. And then he presented with came to me. I involved in the scare when he presented with colitis. But before that, at age 18, he had he went into OR for a presumed appendicitis, and but in the OR during the surgery, he was diagnosed with Crohn's disease, and which mimicked appendicitis. So it was like ileocecal involvement. And he received treatment for medical treatment for Crohn's disease, which kept him on and off quiet. But in the meantime, he had recurrent poor healing ulcers all over the legs and thighs. And then he developed severe gingivitis and periodontitis, and lost his permanent teeth. At age 27, he had to go through another emergency laparotomy, but for this time he had ileocecal stenosis of the end of the small intestine, and ended up having hemicolectomy. What you're seeing here is in this barium study is that very pooled barium at 2 levels here, and then very stenotic segment. And his colitis was very prominent, as you can see. This is Crohn's type of colitis with a lot of bleeding, ulceration, membrane formation, and the biopsy. Interestingly, of course, you would think that what you're looking here on the right-hand side, besides the ulcerated mucosa, you could see this is a blood vessel. Red cells, there are neutrophils in the vessel, but there is a paucity of neutrophils in the tissues. You could see monocytes and lymphocytes or eosinophils in the tissues because there are some other alternate ligand receptor pairs that they can pull out themselves into tissues, but neutrophils don't have that one specific VLA4 we can one pair to let those neutrophils to go into the tissues. So it's a biopsy. When you biopsy a Crohn's colitis of an LAD-1 patient, you see no neutrophils or very few neutrophils, but quite a bit of lymphocytes and eosinophils. The other problem, the big issue, I think, that has kept us busy at NIH is the skin-related complications. There are patients with LAD-1 develop these ulcers. They sometimes start as a little a blister, they expand, become ulcerated, almost like skin is peeling off. It can be very difficult to heal. Try many different things to heal them, and sometimes heals with a fake scab, and they most of the time they leave. What you're seeing here is like a they describe, old immunologists describe as a cigarette paper kind of skin, like this not well healed fine scar forming shiny skin. And in the biopsies, again, there's no neutrophils, but there are lymphocytes and monocytes. And then this whole issue of that, there's this whole scab formation. That's one of our patients who had this big staph infection and big ulcer, which he formed the scab, but couldn't leave that get rid of that scab because you need the neutrophils and the tissue to be able to kind of heal that, get rid of that scab. And in the absence of neutrophils in the tissues, this kind of formed like a little horn, and it had to be surgically removed and grafted. Again, I mentioned you warts, and it's usually very unusual to see warts on the face and the lips. But a couple of our patients had developed these warts on the lips, the face, this cluster of flat warts over the hands, extremities. This is much different than the occasional warts you see on the fingers of otherwise healthy teenagers. They don't go away usually on their own. And then on this whole issue of genital warts is pretty significant and has become a big complicating factor for several young adult patients. And of course, these are patients that have not been transplanted and didn't have the option of being transplanted as young folks. One other common problem that we see, I mentioned autoimmunity or inflammation in this disease, which is not really well known, but we have had a couple of patients that had developed myositis, which is inflammation of muscles. And this patient had in the abductor and the thigh and the quadricep muscles very scattered and presented with leg pain and difficulty moving, going up and down the stairs. Luckily, this is a disease that responds to steroids and immunomodulators very easily. I mentioned colitis, but I want to show you how bad the gingivitis can be. As you can see, the gingiva is retracted, and you can see part of the root of the teeth, and this makes the teeth very loose. And this is because of the our mouth has a lot of oral bacterial flora as part of our oral health, right? And in the absence of neutrophils, there is the signal coming from bacteria is not handled properly. And I'll talk a little bit more. And there's a heavy involvement of cytokine imbalance in the gingiva, which leads to this very aggressive, progressive loss of bone underlying this gingiva, but also significant gingival inflammation. And this whole issue, looking at the teeth in the gingiva, it was discovered that LAD-I patients with severe periodontitis had very high levels of IL-17. It's a cytokine that has some significant relevant roles. And if you look at here, IL-17 is very important. Neutrophils and macrophages are the target. And it is involved in recruitment of other inflammatory cells, and it induces a lot of other induction of inflammatory mediators. But the story is what happens in the tissues when there is no neutrophils is a little different. And we taught ourselves about this. We had to learn about this. Normally, macrophages, these are the fat, bigger white blood cells, or the monocytes become macrophages in the tissues. They secrete what we call another cytokine called IL-23, which induces the T cells to make IL-17. And IL-17 is normally is what recruits neutrophils, is involved in inflammation, and is responsible for bone loss. But when there is neutrophils can tell the macrophages stop, and is able to make macrophages stop making IL-23, which then wouldn't go and make the T cells make more IL-17. So in the patients in LAD-I, when there's no neutrophil, this whole feedback loop is broken. So there is an unopposed IL-17 secretion in the gingiva, in the tissues, and IL-17 keeps doing what it knows to do, causes inflammation, causes bone loss. So we had this whole idea about finding about IL-17 and in gingiva came to life. There was one young man from Italy that was visiting us, and he had moderate LAD1. He didn't have significant infection, and he still had his permanent teeth at age 20, but they were getting loose. So he had severe perianal wounds, such as gangrenosom type ulcers too. So he wanted to try, and we had this, we were able to offer him a drug that is able to turn off IL-17 production through turning off IL-23. And it is a drug called ustekinumab, which is, this is the generic name, which is on the market for the treatment of psoriasis. So it is very effective at turning IL-17 and turning off the Th17, the T cells that make a lot of IL-17, because it binds to a receptor that prevents efficacy of IL-23. And this works very well in blocking this receptor. Had helped us properly and efficiently stop the gingival inflammation, gingivitis, in this patient. This was one patient, of course, but we took this on, and there has been a clinical trial of ustekinumab in LAD1 patients, predominantly those that have gingivitis, that have teeth still in place, but also we have used it to treat very difficult to heal skin ulcers and other autoimmune problems like colitis, ulcerative colitis that we see in LAD1. So short of giving them a bone marrow transplant or gene therapy, if patients are not eligible for bone marrow transplant or don't have match donors, this has been a salvage therapy for us to create the ongoing inflammatory problems. But in reality, the cure is possible. Yes, with bone marrow transplant, the cure is possible. Although bone marrow transplant in LAD1 has been somewhat more difficult than other immunodeficiency disorders. And those, I'm aware of a lot of failed bone marrow transplants, and partially because maybe 10 years ago we didn't know that it absolutely required myeloablative treatment, meaning that a lot of chemotherapy, radiation therapy, to be able to make more room to help the incoming donor cells, bone marrow, to engraft. And even under those conditions, there have been complications, problems. It's not an easy disease transplant for sure. Younger patients, infants, toddlers do much better. I think as part of the resilience, their ability to handle transplant, but probably also the disease load is not as bad, not as much inflammation, not as much crazy cytokines. The nice thing, I think the revolutionary thing last couple of years has been gene therapy for LAD1. In, I think, early 2000s, there was a trial out of Seattle, and several of our patients, my patients that I got involved with, tried this, had that gene therapy. They were able to see transiently increase of CD8 expression, but it didn't last long. So it was a very temporary gene therapy, early days of gene therapy. Now, this trial has 3 centers that is being carried on in US. This UCLA is one of the centers that gene therapy for LAD1 is going on, and there's another center in Spain. There's a third center, I cannot remember, but what they are doing is they are using a lentiviral vector, transfecting the patient's bone marrow derived stem cells and giving it back to the patients as like a transfusion, and having these stem cells grow in the bone marrow that express normal amount of CD18. And I want to finish with this news article from the UCLA's success in gene therapy of one patient, and I think it's a happy story, happy ending for a patient who couldn't get a bone marrow, didn't get a bone marrow, and to be able to be part of this gene therapy. One of the inclusion criteria is that patients don't have a matched a bone marrow donor, and they're not trying to jump in front of the bone marrow transplant. But I think once they show safety and efficacy of the gene therapy, it will most likely be preferred many of cure or permanent treatment. I will stop here, and I got over like a few minutes over my time, and I'll be happy to answer your questions. The things that I may have not mentioned, please feel free to bring it up and ask questions.
Wonderful. Thank you so much, Dr. Uzel, for providing that overview of LAD1. We now have some time available for Q&A, but before we begin, please remember that everyone's treatment and condition are unique. The information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. All right, so we have some great questions in the queue, and just friendly reminder to our audience, if you'd like to ask anything, to please enter your question into the Q&A box. All right, Dr. Uzel, first question. Can you explain how LAD1 is different from LAD2 or LAD3? Oh, Dr. Uzel, you have to unmute.
Sure. First of all, LAD1 is much more common than LAD2 and LAD3. And LAD2 and LAD3, the mutation is the glycosylation problem, which is other ligands that are involved in the tethering or loose rolling of neutrophils are defective. And they are defective because the proteins that are involved in that process are not normally glycosylated sugar wraps. So those defects can have similar features. They wound problem, infection, but there are other features too, like some more neurological developmental delays, because what is involved in that glycosylation process also affects neurodevelopment too. So it is LAD1 plus. In that sense, it is, but much rare compared to LAD1.
Thank you, Dr. Uzel. All right, next question. Is there genetic testing available for LAD?
Yes, you can ask targeted genetic sequencing, which is you ask for the gene that encodes for CD18, which is ITGB2, or you could ask for CD18 sequencing. And it is commercially available to several labs that do this. But most often what we do, because sometimes patient is unclear if it's an LAD1, if the features are not very clear early on, young patients has leukocytosis, and we don't see any problem with the cord separation. Then we do a PID panel, meaning primary immunodeficiency panel. We ask for that, and the price of that has significantly decreased last 5 years. So you get this panel, and they look at every gene that is known, that is relevant to primary immunodeficiency, and they tell you if they found any variants or mutations that can explain and maybe leading to LAD1 or not.
Thank you, Dr. Uzel. All right, the next question. This individual would like to know, if I have recurrent infections and dental issues, should I look into a LAD diagnosis?
If you have, I mean, the dental issue, remember the picture that I showed is a very severe, significant gingivitis that the teeth are usually very loose, and you're losing your gingiva. It's very inflamed. It is very rare for an adult patient with LAD1 to have full teeth and just have mild dental issues. If you are seeing an endodontist, like if you're severe gingivitis, which is what the dental disease is, should be able to recognize what LAD1 is, and that person should be able to direct you. If your endodontist, your dentist thinks your gingivitis is that severe, and you have very severe bacterial infections, yes, the testing is available, and it is usually, I would advise you to usually see an evaluated by an immunologist in the community, and they would be the ones to order the test. They usually, the genetic testing, these labs wanted to come to a physician because so that you can charge your insurance. Insurances pay for the genetic testing, but it has to come to a physician.
Thank you. All right, our next question. This individual wants to know, are severe GI issues common with LAD1?
Yes, it's common. It is common. Not everybody has the same degree of colitis or enteritis, but most patients that I have taken care of with LAD1 had developed some version of inflammatory bowel disease and colitis throughout their life. Some are very severe, like the gentleman, the pictures that I showed you, had to have part of his bowel resected. Some patients have undergone a lot of colitis treatment, like Crohn's disease patients, otherwise Crohn's patients get. I'm aware of a couple of patients that ended up with colostomy. So yes, the GI disease can be very severe, but it's not a rule. Occasionally, we have patients that don't have that significant colitis.
Thank you. And then we're going to close out with this last question, which I'm going to turn into a two-parter. The first part, how do I look into getting gene therapy for LAD?
So the Center for UCLA is an active site. They are recruiting patients, and the name of the I can't tell you the name of the company. There's a very nice website. Actually, I should have put it up. I might be able to send that to you. I think it is Rocket Sciences. If you Google LAD1 gene therapy, you will get the website for this company that prepared the vector for the gene therapy, and it's the same one company that's supporting 3 different centers, providing them with the gene correction method in the vector. Just Google LAD1 gene therapy, and I think it is Rocket Pharma, and there are in their website, it will direct you to UCLA's website for this gene therapy, and there are inclusion and exclusion criteria, and you can and there's connection to how you can reach to the people running the trial.
Thank you. And I just want to add also, if you go to clinicaltrials.gov and you search for LAD, you should be able to find the gene therapy clinical trials that way as well. So my follow-up question to that, so I thought I heard you say in your talk that gene therapy is only available if the individual is not able to find a matched donor for hematopoietic stem cell transplant. Is that true?
That's true. That was their inclusion criteria.
Okay.
Yeah. I mean, is it going to change? It probably will change once they do the first phases to prove safety and efficacy. Because gene therapy elsewhere for other diseases have had its own problems, right? And they don't want to jump in front of the bone marrow transplant that they or FDA doesn't want them to claim that gene therapy is superior to bone marrow transplant. Because hasn't been proven for sure yet, but once they show its efficacy and safety, I think in a couple of years they'll be able to extend this cohort to those that have potential donors, but the whole issue of transplant is a risk for the patient. For example, if the patient has lung disease, or had significant colitis or other LAD related complications, it might be risky for them to undergo transplant, for example, let's say. So those for those patients, I think the future will be much easier if they go through gene therapy, not having to expose that amount of radiation and chemotherapy for transplant. So I think it is going to happen. They just have to go through this initial phase of proving safety and efficacy.
Certainly. Well, thank you so much, Dr. Uzel. To our audience, our time this evening is coming to an end. Thank you so much again, Dr. Uzel, for sharing your time and expertise with us this evening. It has been such an honor to have you join us today. This session is one of 39 unique learning opportunities provided through our 2023 PI conference. And we hope you continue tuning in tomorrow as we pick up our schedule again and we explore other critical topics for the PI community. Hope you all have a great evening.
Thank you very much. Have a good night.
Thank you.